Hello and welcome back to my YouTube channel. Today, while I'm sharing my screen, I'm going to speak about a very controversial and interesting topics, the topics of the punctate white matter lesion of the neonate that somebody called in one beautiful paper the brain kryptonite. Um, so the important thing is that to stress is that I did this lecture for the European Society of Pediatric Radiology in Belgrade this year, in particular for the course of the advanced course in pediatric imaging. It was very interesting neonatal session. What I would like to, and I will put the link for the society if you are interested in the pediatric imaging, please consider becoming a member and participating to their events. So let's start with this topic. When we see small punctate lesion in a neonate, how we interpret? Does it make any difference if they are hemorrhagic, i.e. they show susceptibility, or not? Does it make any difference if they are associated with linear lesions or not? Can they be found in normal children without any prognostication issues or poor prognostication rather, or are they always pathological? Can they be found only in isolation or in association with other neonatal pathology? I will try to answer to all these questions as far as the literature goes, because this is, as I said, a controversial topic. But what I really would like to do is to show you guys how to approach this punctate foci or abnormal signal in the knee. So let's start with the typical and well-known pattern of hypoxic ischemic injury in a neonate. What are the expected brain patterns in this age group? So first of all, you know the basal ganglia thalamus pattern. They say, historically, that this is the typical pattern, as you can see here, in T1, bright signal, in T2, abnormal, again, hyperintense signal. Here, this more, even more typical posterior lateral putamen and lateral thalamus signal normality, very typical of hypoxic ischemic injury at term, and historically they say this is typical of acute profound, so-called near total hypoxia, more than 10 minutes, because we know that less than 10 minutes the brain should be able to get away without damage. Okay, that's the first pattern. We will come to that later, but for now, acute profound HIE basal ganglia pattern is the first well-recognized neonatal pattern reflective of ischemia. Of course, this is neonate at term. When we have a watershed pattern, like in this case, you can see this is a diffusion. You see the cortical, subcortical abnormality with secondary involvement of the corpus callosum with some areas of edema and cortical highlighting in T1. This is one of our cases. This is a case from literature. Again, watershed areas of restriction in this ADC map and edema. In these cases, we call watershed pattern indicative of prolonged partial hypoxia. Sometimes can be very long, like this case was 1.5 hours. And then we have this total or global brain injury that is normally related to a severe and prolonged partial hypoxia. You see this diffuse edema and restriction. And in this beautiful paper by Coscino and colleagues, you see how this restriction involving the whole brain in ADC and DWI then evolve over time involving in this case mainly the white matter, also including the white matter tracts in the nucleocapsular region here, and then evolving chronically in, unfortunately, a diffuse encephalomalacia. Now, if you read the radiological literature, and this is important to take in mind, to keep in mind, they will describe total brain injury as marked and profound acute hypoxia sometimes. But actually, if you speak with the neonatologist and pediatric neurologist, they know that this pattern is often associated with severe and prolonged partial hypoxia, because the partial hypoxia can have different levels of severity. So keep in mind also this. And finally, these were mainly term neonatal patterns, but if you have a preterm, you have the famous PVL, sometimes very marked. We tend to do not see this anymore. We see more like this case on the right-hand side with basically abnormal signal in the periventricular white matter. This is very abnormal because it's associated with squaring of the ventricles, reduction of the size of the posterior corpus callosum. Don't call this perivascular space or terminal zone of myelination, because this is, especially in the context of spastic dysplasia, a form of PVL. And this PVL is typical of preterm neonates which suffer HI. This is already complex enough, but actually, if we check the literature written by the neonatologist, from which we can learn a lot, to be fair, we see that there is a lot of controversies or a lot of overlap in the clinical radiological findings. For instance, if we focus, this is from the Neonatal Encephalopathy and Neurological Outcome book from the Society of Neonatology and Obstetrics in America, and you can download this for free online. But let's, for instance, focus here. The deep nuclear gray matter is the most common, and you have deep nuclear neuronal injury, so the basal ganglia pattern. But if you see the example of risk factor, they say that this is due to severe partial insult of prolonged duration, or a combined partial with profound terminal insult. So it's not just the profound near total insult that give you that pattern. A profound or prolonged insult can give you widespread neuronal injury with the diffuse or global injury, and so on. The deep nuclear gray matter alone, due to acute total hypoxia ischemic insult, is quite rare. So most of the time, reading this book and the chapter dedicated to radiology, we figured out that most of the time the deep nuclear gray matter are due to a prolonged plus an acute insult rather than an acute total ischemia alone. And I learned that studying for this presentation, so I wanted to show you this overlap, so don't be very dogmatic in your report. But as far as the white matter abnormalities are concerned, when it comes to white matter injury, we can have periventricular leukomalacia, but also milder non-cystic form, seen in 10 to 20% of the cases. And these are our punctate white matter lesion. So if you look at the literature related to punctate white matter lesion, there is a lot of papers with some confusion, and the culmination of this confusion was when I found this paper here that was all in Chinese, I guess. So I'm not sure what it says, but I'm sure it's about punctate white matter lesion and DTI. So I think I showed you that when it comes to neonatal encephalopathy, there is a lot of overlap, some controversies, different patterns, radiological patterns that overlap with different clinical scenarios. And on top of that, the punctate white matter lesion stands out as the most difficult to interpret findings that we can find in this. So let's start from there. Are punctate white matter lesions normal or abnormal? There is an amazing paper published recently on AJNR from the group of Sheffield, where they analyzed, basically assessed the prevalence of punctate white matter lesion in neonate with no clinical sign of hypoxic ischemic injury. Basically, normal neonates, they are a big neonatal unit here in UK, and they found that 40 normal patient, of 40 normal patient, only one had one single punctate white matter lesion, which of course gives no problem in terms of prognostication. This child will have a very good prognosis. So basically, if you see punctate white matter lesion, especially if there are multiple, these are not normal. Okay, so that's the first point that you need to keep in mind. You see punctate white matter lesions, these are most likely pathological. It's very rare to have a punctate white matter lesion in a completely normal child, and the only case they found was just one isolated, non-specific. So punctate white matter lesions are not normal, first point. Then, reading the literature, I figured out that there is this relationship with deep medullary veins that sometimes has been stressed when it comes to punctate white matter lesion. So deep medullary veins or not, quoting Shakespeare, that's the problem. So let's start to dig into the literature. First, I want to show you these two cases that came to Great Ormond Street from external hospital. Both of them were labeled as neonatal stroke on the ground of these areas of diffusion restriction, one on the right, one on the left, interpreted as diffusion restriction in the territory of the middle cerebral artery. But you can see that this diffusion restriction has actually a linear shape that is confirmed on T2 as area of hypointensity. We know that the neonatal brain is not myelinated at birth, so everything abnormal will be hypointense in T2 and hyperintense in T1 on a background of unmyelinated white matter. And this is actually not an MCA infarction. If you look at this linear course, they is anatomically correspond to the course of the deep medullary vein that drains through the brain parenchyma. And this is confirmed on the same two cases on the susceptibility, where this engorgement / thrombosis, we call engorge rather than thrombosis because this tends to resolve spontaneously, is confirmed as these linear areas of hypointensity on gradient T2. So these are actually punctate white matter lesion along the course of the deep medullary vein. And I reported this as punctate white matter lesion associated with deep medullary vein thrombosis of engorgement. Now, the problem is, there is this association. Is always like that? What is the significance? So let's, as I said, check the literature. This is a scoring system that was attempted for the white matter injury in the deep medullary vein territories. It's just to show the scoring system. I don't want to focus on the scoring system per se, but looks all this linear area bilateral with associated punctate foci abnormality. In these cases, there is also restriction, and they identify several risk factors. I want to stress, among others, the fatal distress and birth asphyxia and sepsis, and also protective factors that are related to the anatomy of the deep medullary vein. So the higher frequency of transcerebral veins in the temporal and occipital region seems to be protective factor. The fact that thinner white matter and shorter medullary vein in the temporal region that we found, thinner white matter and shorter medullary vein in temporal region, was also another protective factor. And this is why they found most of the punctate white matter lesion in the frontoparietal regions in association with deep medullary vein thrombosis or engorgement. So there is an association, and we know that there is an association because these areas of abnormality tend to develop more in the areas where the deep medullary veins are more susceptible, okay? And this is a fabulous paper in AJNR 2011 by Filippo Arrigoni and colleagues from the group of Milan that again show very well this association with deep medullary vein thrombosis. And they say that the deep medullary vein engorgement is associated with these punctate infarction that are often hemorrhagic, and the association is with, again, difficult delivery, sometimes seizure, and they can have diffusion restriction. They can have diffusion restriction or not. They can have hemorrhagic changes or not. So they look like venous infarction in different stage of development. The etiology is much less clear, and they want to stress this. But of course, prematurity, hypoperfusion in term or preterm infants is also they are also a risk factor, and this can be found in preterms, but also in terms baby. So, just to recap, there is an association with deep medullary vein thrombosis and engorgement, and we can see this engorgement as linear abnormalities in association with punctate foci abnormal signal in the neonate. So remember, they stress this fact that not only preterm baby as initial report are susceptible to this punctate white matter lesion, but also term baby. So we are starting slowly to put together the pieces of a very complex puzzle that I will recap at the end of this lecture. Now I want to come back to 2002, a paper from different authors, including some Italians, neonatology, and they show that basically, again, this is often, we can find the punctate white matter lesion often in preterms, but these are not exclusive of preterms. They are often linearly organized, again confirming this association with the deep medullary vein. And the prognosis is dependent on the number and the clusterization of this lesion. In other words, and quite intuitively, the more the punctate lesion, the more clustered together, the more in critical areas of the brain, the worse the prognosis. And this is very useful for you guys because you need to report this as such. So you need to stress if these punctate lesions are along the course, for instance, of the corticospinal tract, if there is secondary degeneration of the white matter fibers. I will show you some example later on, and also how many of these lesions are there. So we have seen that they are not normal. We have seen this association with the deep medullary vein. We've seen this different prognosis depending on the number and location. Are all punctate white matter lesions the same? So what's the nature of the punctate white matter lesion? This is much more difficult question to answer, but it's very interesting. So again, let's go to the literature. This paper back in 2011 showed that again they can be they can have susceptibility or they can have restriction, but these are not constant findings. So they can be DWI positive and SWI positive or negative. And they try to think what is the difference between the susceptibility, the positivity or negativity in susceptibility and in DWI. They also show that sometimes they reduce in number over time, but this is a controversial findings. I want to come back later on. And they show that in a few cases where they had the histology, they found early gliosis in the SWI negative lesion. So basically they say they can be hemorrhagic or not, they can restrict or not. The ones that are not hemorrhagic, they are small areas of early gliosis, so small ischemic areas. So they say that the hemorrhagic lesions are associated more often with intraventricular hemorrhage, and they are very close with the deep medullary vein. So in other words, they say the one associated with the deep medullary veins, engorgement / thrombosis, are often hemorrhagic. But we also have, sometimes in combination, sometimes in isolation, non-hemorrhagic lesions, and these are gliotic lesions non-associated with deep medullary vein. So there are two different kinds of punctate white matter lesion, potentially with two different mechanisms and risk factor involved, but they can be found in the same patient as showed in this histological space. So let's recap. What is the nature? So Niva and colleagues say that some punctate white matter lesion may be venous hemorrhagic infarction along the course of the deep medullary vein that are congested or engorged or thrombosed, as you want to call it, while other are non-hemorrhagic infarction with gliosis. So two types of deep medullary vein. The pathogenesis is still a matter of debate, but it seems that the SWI is associated with different risk factors. So there may be a nosological difference between the SWI positive and SWI negative. So in other words, the one that are only gliotic, far away from the deep medullary vein, non-hemorrhagic SWI negative, may be different in terms of pathogenesis from the one that are hemorrhagic and close to the deep medullary vein. That's a recent paper from the group of Gaslini Hospital in Genoa. Coming back to a seminal paper from Charles Rebaud, he said that again, the punctate white matter lesion, the hemorrhagic punctate white matter lesion have likely different pathogenesis from the non-hemorrhagic, but we don't know precisely what are the factors involved yet. So, just to recap, two types, hemorrhagic and linear, associated with deep medullary vein, non-hemorrhagic and focal. So what's the cause of punctate white matter lesion? There are a lot of interesting papers. This is on the right, a paper from Guyen and colleague that I used for my for the title of my presentation. I love the brain kryptonite title, and so they say that there is an association with perinatal asphyxia, but also infection or inflammation, and of course, congenital heart disease and genetic disorders needs to be considered because congenital heart disease has a strong association, as you know, with abnormalities in the brain. But most of the cases, we need to exclude the perinatal asphyxia, infection, and inflammation. Some papers say the evolution, as I said before, some papers stress the fact that this lesion disappear. But other papers say, well, they disappear radiologically if you do early follow-up. But then if you do a follow-up later on down the line, you will see that they will result in scarring. And this is actually consistent with the histology that there are either hemorrhagic infarctions or gliotic ischemias, gliotic areas. So we do expect some scarring, and we can have some consequences in the neurological development of the child, depending on the location and the number, as I said. So probably although some papers say that they disappear, actually, if you read the whole literature, it seems they just become less visible radiologically on an early follow-up, but then they reappear as a loss of volume and scarring. And this is confirmed also on some DTI studies. Okay, so that's important because as a general rule, the way you interpret the literature is very important. Don't just read the paper and take the conclusion as a gospel per se, especially when it comes to complex findings. There are associations with secondary degeneration of the large white matter fibers. Look at this punctate white matter lesion in diffusion, and the corpus callosum and the posterior limb of the internal capsule are hyper intense in DWI. So this is called pre-Wallerian degeneration. Why is very important? Because we know from other studies that whenever we have in a neonate pre-Wallerian degeneration of the large fibers, we have a prognostication impact and a worse prognosis for the child. So you need to tell your neonatologist, your neurologist, when there is this secondary involvement of the white matter fiber. And this is the typical phase of two radiologists leaving the reporting room to see a patient. We are very scared of the light and to go out from our dark reporting room, but I think it's good in this case to when speaking about this complex topic to show some real life cases. So first case is this child with profound HIE with that underwent therapeutic cooling. So you know when there is a clinical evidence of HIE, positive ischemic encephalopathy, children they go to therapeutic cooling, and sometimes it works very well. In this case, despite the profound HIE, we just found a couple of punctate white matter lesion restricting in this case. And the conclusion from the multidisciplinary meeting was that this was a acute profound HIE 10 to 15 minutes. So we would expect some basal ganglia damage, but the basal ganglia damage didn't appear because of cooling. So the cooling worked. Nevertheless, a bit of damage appears in a form of punctate white matter lesion. So punctate white matter lesion can be expression of a well-treated profound HIE. This is another case with hypoglycemia and prolonged partial HIE. Now, look carefully at the T2. There is edema here in the posterior aspect of the brain on T2. And although this is DWI affected by artifact, you see the optic radiation showing restriction and the posterior limb of the internal capsule also showing restriction. So this is prevalent degeneration. This is hypoglycemia damage typically involving the posterior aspect of the brain. But looking a bit cranially, you can see also these three punctate white matter lesions showing diffusion restriction. So again, they don't have susceptibility, so probably these are areas of gliosis. So again, they can be associated with other form of neonatal encephalopathy. In this case, they were associated with hypoglycemia and prolonged partial HIE. So again, a mild damage of the white matter in form of a punctate white matter lesion overlapping with a well-known damage in the neonate. 9 days with the total brain injury due to a severe prolonged hypoxia. Look at the edema here involving the whole brain in T2, and this restriction also involving the main fibers, white matter fibers in the brain. But look, there are also hemorrhagic punctate white matter lesion in the periventricular posterior temporal white matter, probably due to a damage of the deep medullary vein. So in this case, we have a child that underwent several hours of severe prolonged partial HIE with total brain injury and associated with SWI positive punctate white matter lesions. So punctate white matter lesion in this case are an epiphenomenon of a diffuse brain damage. Of course, this will not impact the prognosis that is already very bad. This is 10-day-old neonate with encephalopathy. We don't know the cause. Maybe asphyxia, maybe inflammation, infection. You see a lot of hemorrhagic punctate white matter lesion, quite large. They probably will have an impact on the prognosis because of the vicinity with corticospinal tract and optic radiation, especially on the right-hand side. So in this case, they are associated with intraventricular hemorrhage. These are hemorrhagic lesion. The prognosis is not good. We don't know the cause, but we need to describe this and we need to speak very clearly with our clinician with regard to the prognosis. Another case for the old with mild to moderate HIE, less than 15 minutes, cooled, again, isolated punctate white matter lesion. What is the prognosis? In this case, opposite to the previous one, the prognosis is very good because it's just one punctate white matter lesion. There are some mimics. I want to stress this case of a 9-day-old presented with fever. So this is infection, most likely, irritability, focal seizure. Look at this diffusion restriction bilateral along the course of the deep medullary vein with prevalent degeneration, much less evident in T2, just probably some areas of abnormality in the plic. This is typical. This is not a deep medullary vein stroke. It's very symmetrical. It's bilateral. The child has infectious flavor, and this is typical of paracovirus or also other viruses that can have the typical white matter involvement along the course of the deep medullary vein, resulting, as you can see here, in scarring. So remember that the infection can also give abnormality along the course of the deep medullary vein with punctate white matter lesion in association, much more diffuse. The children will have an infectious flavor clinically. So remember this important mimic. And this is a child with sepsis clinically. Again, look, a lot of punctate white matter lesion bilaterally along the course of the deep medullary vein. This is not normal appearance here everywhere, especially visible in diffusion with, again, prevalent degeneration of the posterior limb of internal capsule. Some are hemorrhagic, some are not hemorrhagic, and the restriction will disappear over time, but we start to have atrophic changes. There is still some susceptibility. So this is an example of sepsis-related punctate white matter lesion. Some of them are restricting, some of them are DWI positive, and the evolution is toward atrophy. So remember that they can be associated not only with asphyxia and, as I said, consider always congenital heart disease, but also infection. And among infection, consider viruses like paracovirus as a cause of large white matter involvement along the course of the deep medullary vein. So to summarize, punctate white matter lesions are pathological. It's very rare to find punctate white matter lesion in a normal baby. And if we find in a normal baby, most likely it would be isolated lesion, 1 or 2 without clinical significance. They can be hemorrhagic, and in this case are linear close to the deep medullary vein, and they can be non-linear, and in this case are associated with ischemia and gliosis. They may have different pathogenesis, but we don't know precisely what is why some of them are hemorrhagic and why some of them are not. Are more frequent in preterm baby, but also present in term baby, and are often in association with perinatal asphyxia. The more lesion, the more critical location, the worse prognosis. Remember to report and tell your clinician when there is a secondary involvement of the corpus callosum and the corticospinal tract in a form of prevalent degeneration, so restriction, diffusion restriction of these tracts. They evolve with scarring and loss of volume, so the more punctate white matter lesion, the more scarring. And remember, they can be not only associated with asphyxia, but with other causes, most important of which will be infection. And if you see bilaterally relatively symmetric diffuse white matter lesion in a neonate with fever, think paracovirus. Okay, so in general, this is very, very important topic. There is still a lot to be studied about this, but it's very important that we know the complex literature related to this topic. Please check out also my other lecture on YouTube. These are street signs from my from back home in my region in Campania, hospital, highway, hospital, Naples, Salerno, right and left. Very confusing. I hope I was less confusing than the street signs back home, but please, if you have any question, get in touch. Thank you very much, and see you next time.